Hi, my name is Jennifer Reyes and I'm going to be doing the demo on the chest drainage units. Usually there's two kinds, the Ocean and the Oasis. One's a wet suction and one's a dry suction. For the wet suction, we are going to insert our sterile water or normal saline. It will come with a funnel. And first off, we're going to bring out there's two little legs here that we can put so that the system will be stable and it goes on the floor. So through the funnel, we're gonna fill up our chamber up to 20 centimeters of water, negative 20 centimeters of water, which is standard for this one. And we're also gonna have a stopcock, which will control the amount of suction that we want. For expected findings, we have our continuous gentle bubbling here. If it bubbles an exaggerated amount, then it can indicate an air leak, in which case we're going to have to troubleshoot. For our dry system, it will actually come with a syringe pre-filled with our saline that we will inject through the little port. And this one, it comes with a dial that is already preset at negative 20. However, we do have to verify with the provider to make sure what the amount of pressure they want is. It also has this E chamber, which is different from the wet one, and it'll blow up like an orange accordion, which should remain like that for the remainder of the suctioning time. We also have our chamber C here, which will also indicate the air leak. As far as suction, it's usually connected to 10 to 20 millimeters of mercury. In order to be prepared at the bedside, we always have our sterile water or normal saline, gauzes, and tape. This is because from the patient's movement or during transport, the tube can actually become dislodged. So if it's the part that is connected to the patient, up until the part that is connected to our suction, that is outside of our scope of practice. So we're not going to be able to do anything about that. What we're gonna do, if it becomes disconnected from here, we're gonna put it into a container with water, our sterile water or saline, to create a water seal. If it becomes disconnected from the actual patient, then that's when we're gonna use our gauze, and we're only gonna tape 3 sides. Standard is 4 sides while the suction is properly working, but once it becomes dislodged, we're just gonna create a little valve until the provider can come look at it. In any case that we do find a leak or it becomes dislodged, we are going to have to call the provider, give them an IS bar. We're not going to leave the patient alone, and if we do, we're going to have someone else come be with them for the time that we're alone, but we'll try not to do that. So once it becomes apparent that there is an air leak and we're going to have to troubleshoot, we're going to do our assessment on the patient, respiratory assessment, which is focused on that, our respirations, any crackles or any sign that they're getting a tension pneumothorax, which is a complication of this. We're going to do hand hygiene, and we're going to put on our gloves. In order to troubleshoot where the air leak is, we're going to have hemostats at the bedside as well, which we will clamp to determine the location. We're going to start at the proximal end of the patient to determine if it's either the tubing that's actually in the patient or the one from the unit. And this is going to be very quickly. We're just going to clamp and clamp, kind of leaving 1 inch so we can determine where it is. And this is going to be very quickly. It should only last seconds because we don't want to clamp too much. This chamber will be bubbling excessively if there is a leak. But once we are able to isolate the leak, it will stop. So at that moment, we unclamp and we're going to let our provider know what's going on. We're going to call with our IS bar, and since we can, as nurses, just replace the unit, we're going to let them know that we're going to do that. And we're going to verify again the settings that they would like it at. So we're gonna leave this here while we set up our new unit the same way that we did. And so we're already gonna have it connected. Everything's gonna be set so that we can just quickly connect it to the patient. Once we're here, we're gonna take off our tape We're gonna loosen it. We're gonna clamp. Turn off our suction, and then at this moment, we put in our new tube, unclamp. We turn on our suction and then tape. All of our supplies should be ready and we should be prepared in the case of an air leak. After we have reconnected, we're gonna go ahead and reassess the patient and make sure that they haven't had any emergent symptoms from the time that we discovered the leak to the time that we're replacing the unit. And of course, let our provider know how they're doing with the new unit. And that's